Well, good afternoon, everybody. It's time for Community First Conversations. I am Courtney Nicolato. I have the absolute privilege of serving as President and CEO of the United Way of Rhode Island. Thanks for joining us. This is our 7th episode of Community First Conversations. As you know, for 95 years, the United Way has been focused on strengthening the Rhode Island community so that every Rhode Islander has an equal chance at a bright and prosperous future. And all too often, for too many Rhode Islanders, that is truly easier said than done. And through the crisis and through COVID, we have heard loud and clear that racial inequities have been plaguing Rhode Islanders for far too long and have as part of COVID as well. And so today we're going to talk about an amazing program that's been in place for years that have been doing just that, targeting inequities in our community so that every Rhode Islander has a bright and prosperous future, and specifically in the area of healthcare. And so we're going to be talking about health equity zones. We define equity as an intentional inclusion of everyone in society. We believe that equity is achieved when systemic, institutional, and historical barriers based on race, gender, sexual orientation, and other identities are dismantled and no longer predict socioeconomic, education, and health-related outcomes. Everywhere you turn, racial inequities are keeping our Black, Indigenous, and people of color from thriving. In healthcare, our state has led the nation in combining these inequities and really looking at creating an innovative collaborative approach. And these are called health equity zones. You may hear the words HEZ as part of the conversation, and that's inside baseball shop, but health equity zones. And today we're very lucky to have the amazing creative and founder of Brainchild. This is the brainchild of Ana Novais, and is joining us to share more with us today. As always, share your questions and your thoughts in the comments section of Facebook Live. We will be incorporating those questions as part of our conversations today. We want to hear from you, what you think about these programs, what questions you have, how you want to learn more. That's what these Community First conversations are all about. So let me introduce Ana to you. She holds a clinical psychology degree from UCLN in Belgium and is a graduate of the Northeastern Public Health Leadership Institute and Leadership Rhode Island, as I am a grad, and Ana was actually my class lead, which I was excited to work with her. Her career started in public health in Cape Verde in 1985 and included 5 years in Portugal. She's been working with the Rhode Island Department of Health since 1998, starting as an education and outreach coordinator, minority health coordinator, and has had numerous roles to this day. And since 2006, she's served as Executive Director of Health. She leads the department efforts to achieve health equity by focusing on disparities, which we'll learn more about today, access to care, chronic disease, environmental health, maternal health, and created the Health Equity Zones Initiative. And so she is now the Deputy Director of the Rhode Island Department of Health. She was born and raised in Cape Verde. Her roots are in Portugal and Angola. She is fluent in Creole, Portuguese, French, Spanish, and English. And so I am completely feeling like I have more work to do in that department. And the proud mom of 4 adult children and grandmother of 5. So Ana, first off, welcome. We're so thrilled to have you. And I'm such a big fan of your work, so I'm excited to share that with the world today.
Thank you so much for having me. I'm excited to be here and look forward for this conversation.
Awesome. So the first question we always ask everyone is, it goes to the roots of who the United Way is. So we have a term at United Way, which is community first. So every decision, everything we do, we always put the lenses, is this put community first? Does this put the community's needs at first? And so everybody has a definition of what community first means to them. So I ask you, what does community first mean to you?
I think community first means that regardless of what you're doing, you put the community first, core and center in your decisions, and not just directing the decisions at them, but making sure that the community is part of that decision process because they know better. communities know better what's important for them, what's needed for them.
I love it. And we can't prescribe exactly what the community needs, right? And I think that's the power of the health equity zones too, is that you bring it to the communities to really say, what is your need, right? What is your challenge that you want to overcome, and bringing folks together to make that change. So I guess
You,
what the health equity zones are. And
yeah, I mean, the community first, it's at the core, in fact, of the definition of what health equity zones are. It was the Department of Health taking a step back and asking ourselves, how do we do a better job at doing public health? So we are sure that we are addressing what's important for the communities, not telling communities what they need, not telling communities what their problems are, but really bringing that voice, core and center, leading the process. So health equity zones are basically community-led collaboratives where a group of stakeholders in a community, defined by them, decide, come together and make an assessment of what's needed in the community, what are the strengths of the community, what are the assets in that community, and then they also, through their own community prioritization process, decide on the priorities that they want to address, decide on solutions that they believe are going to work for that community, and to come up with a plan of action. Our role as public health in the background is to support that process, support that engagement, and then clearly important, find the funding necessary to be able to implement that plan of action. So it's not just a document in someone's shelves, but it's an active guide that the community is using to decide on what's next and how to do that.
And I love the fact that there's a wide variety of concentrations in these health equity zones. Will you share a little bit about what certain communities are doing to combat the issues that are facing their community?
Absolutely. So first, let me start by saying that every health equity zone is different by definition. It's different by size. It's different based on who's leading or not leading, who's supporting and leading on a sense, that community process. We use a collective impact framework, meaning every collaborative identifies a backbone organization that I see as the glue, not the decision maker, but the glue and the facilitator of that collaborative process. We have some that are as small as a neighborhood in Providence, as big as a city, like Bristol, as big as two cities, Pawtucket and Central Falls, or as big as a county. We have at some counties. So that's different. Some are led by health systems, federal qualified health centers, school system, or a municipality, or an organization such as LISC, which is a community building, community development organization. And their priorities differ. But some of them are constant. One thing we saw last year was that mostly 8 out of the 10, 11 that we have right now had identified drug overdose as a problem. And so they had come up with different solutions for drug overdose that went from building up a drop-in center to providing training for Narcan use and so forth. People identified issues that were related with much more underlying root causes of issues, from transportation, having lack of no RIPTA bus going through the community health center. It started with an assessment of we don't have access to care, and then it's realizing that you don't have access to care because you don't have bus and the transportation to the source of care that you do have in your community. And they worked on a solution with RIPTA to have a bus line through that. Or job training in Pawtucket and Central Falls, and they were able to come up with a program that brought youth that were somehow otherwise involved with DCYF, for example, or the training school, or in a potential high-risk situation, and put them on a training program, provided that support led to job opportunities. So it really varies from community to community, and it goes from everything from access to care, transportation, access to food, drug and overdose, drug use, overdose prevention, chronic disease prevention, maternal and child health. So it's really all, they have basically two main goals that we have: addressing, uh, making sure they address disparities, making sure that whatever disease, chronic disease, maternal and child health issue, it's addressed from a policy and system level perspective and not just the immediate service Band-Aid perspective.
And talk a little bit about, the success. You've had all of these communities. I think really for me, one of the biggest successes I've seen is you've had these community partners all coming together, determining what the issue and challenge they want to confront together, and then all go in to make that change, right? So, but there's also been health outcomes, right? And so share a little bit about the successes of the program to date.
So you hit it in the nail when you say the biggest success is that community process. It's the build out of the community infrastructure that did not exist at the local level before. We are a system that is decentralized public health, don't have local public health infrastructure. We are a state with statewide infrastructure and nothing at the local level. So we rely on community-based organizations such as the United Way and many other partners to be that local infrastructure. But it was not organized in a way of leveraging resources and bringing everyone's attention to an agreed upon goal. And so that collaborative process for me, it's the biggest success of the health equity zones, the having a ready to be invested on infrastructure that delivers immediately in results. It's there, it's engaged, and it's recognized. Like right now with COVID response, when we saw a resurgence of cases in Pawtucket and Central Falls, for example, we were able to immediately rely on the health equity zone in Pawtucket and Central Falls, activated them in terms of not just supply distribution, PPE distribution, masks, and all of those things, but also reaching out to local vendors, to local restaurants, and so forth to educate and assure that in terms of community mitigation measures were in place. But that's today with COVID. In the past, in terms of specific health outcomes, we've seen tremendous changes in things such as teen pregnancy in Pawtucket and Central Falls. I have, like, for example, in Pawtucket, we had a 44% decrease in childhood lead poisoning prevention in those first 4 years. And that's an amazing change that we had never seen so drastic in that small period of time. Or a 24% decrease in teen pregnancy in Central Falls. That's an amazing result when you think about it from that perspective. In West Elmwood, Southside Providence, it's another health equity zone. They had identified feeling of loneliness in the population and isolation. They were able to have a change of 13% decrease in that feeling of loneliness in the community. And so we have many more of those. One important one for me, statewide, we had an increase in community engagement that was evaluated at 163%. And that tells you the level of change that you are seeing in how communities are coming together to be part of the process instead of being recipients of some part of a program or an initiative. They are the initiative.
I love it. And I firmly believe you cannot build a stronger neighborhood unless the neighbors are bought in, right? And to me, this is just such a perfect example, and those results are such perfect examples of what happens when neighbors help neighbors and folks come together and folks are committed to growing a more healthy community.
And that's a challenge many times, to have true meaningful community engagement, resident engagement. There is a tendency to see engagement from the lens of just the organization itself that represents the residents, but not truly bring residents to the table. So one of the critical components of HAS was that true meaningful engagement with communities. So we saw health equity zones that took the time to have community conversations, bring residents to the table, ask them what health means to you, what are the important issues you want to address in your neighborhood, continue to engage with them as they develop plans of action. So they felt the ownership and they were able to participate and be fully engaged. And we saw, for example, folks that started as one resident recipient of services, and by the end of this process, it's now a coordinator in one of our health equity zones, that went from being that recipient of service to being trained to become a community health worker, to then engage, be a volunteer with the HAS, and now being one of our managers. And so that is through engagement, not just from the being part of the process, but really participating and taking ownership in a variety of ways.
And my guess is that through this process, there's been tweaks along the way, right? Because I always feel you never go into it right away having all the answers.
No.
And that community feedback must have contributed to that, but also like the adaptability of a community to just, tweak here and there till they get it right? Until they get that outcome that they were looking for.
And that tweaking is not just at the community level, I must say. It was a tweaking that needed to happen at the department level, because we're not used to do that. It's hard for the department. It was hard for us to move from the traditional perspective that public health knows it all and has all of the answers, to this and a disease focused approach that we usually have. We do tobacco prevention, or we do obesity prevention, to this comprehensive approach that really shifts the power towards the community. That's challenging to us, because many times they take you in a direction that you are not prepared to do. So that tweaking and that learning has been a journey, both for us as a department, but for our communities too, on how to navigate, for example, local politics. When you have a health equity zone led by a city, for example, how easy or not it is to navigate that voice of that community and maintain an equal power distribution. So we have learned together. We have a learning collaborative where we bring all of the partners together, and we try to address these questions and learn from one to the other. What's happening here in Pawtucket that you can translate into Woonsocket, into West Warwick, and so forth. And that's been extremely helpful. And we are also having our first cohort of HAS. We started in 2015 with 10. And so they had a full cohort for 4 years. And then last year, March, we started the second cohort. We brought 3 new ones. And it's interesting to see how much the first cohort can work as like a peer support to the second cohort and address with them, oh yeah, we got that. We have an answer. Does it work for you? So that's definitely an ongoing learning process for both of us.
That's great. And I know the funding is what's called braided, right? So, and there must have been some learning at the federal government perspective too, on trying something new and being innovative and being allow communities to make decisions on behalf of themselves. So there has been learning all across the board.
Oh, absolutely. I mean, we all know there was no such thing as funding for health equity zones. There was no such thing as a book on how to do health equity zones. We were doing it as learning and writing it as we were doing. And funding was a critical issue because we get funding from the federal level categorically, and we wanted to create this system where we're not focusing and engaging with the communities from a disease-specific perspective, but more comprehensively. So we came up with the Braided Funding, which is an approach where what we did was allow the communities to come up with their work plan based on their community priorities. And then based on the work plan and a mapping of all of the funding that was available to us, we were able to pull from that braid the funding that was appropriate to support A, B, and C at the community level. So for the community, it was a more smooth process. For us, it had much more work at the back end in terms of making sure that the accountability of the grant was intact. It had its back and forth at the beginning with the community because we've learned on how to do this process. We needed to change how to do grant management at the state level. And so there were times that, yes, we had kind of these with the community because we asked a lot of questions to be able to document back to the feds. But I think there was this understanding from the get-go at both ends, us and the community, that we were trying together and learning together. And yes, we were going to make mistakes, but we needed to stay on it together. that allowed us to put pressure on the feds for them to understand that this was innovative, that this was creative, and they needed to be able to support us. And they have been supportive. They've recognized it as a best practice. In fact, today, it's somewhere in my table, I just got an award from the National Association of Maternal and Child Health Programs for our stakeholder engagement and community impact through the health equity zones, recognizing the work of the health equity zones. But for me, it's truly a recognition of the work of our communities, of what they are doing, because the success of the health equity zones is the success of our local communities. They do the work.
Yeah, in talking about all of the complexities of the process, I am constantly reminded that innovation is not easy.
Yeah.
If innovation was easy, everybody would do it, and it comes up with these barriers, and you have to think through them and process and go, you know what, we got this, we'll figure it out. You're right. And so that's awesome. And one of the things that I'd love for you to share, speaking of innovation, is a little bit of details about how the health equity zones came about. I think it's an inspiring story of innovation. So would you mind sharing a little bit about how it came to be?
Absolutely. So I think it goes back to, on a sense, a little of my own personal journey within the health department. And so one of my first jobs, as you probably know, I don't know, it's in my bio, but was as an education and outreach coordinator for lead poisoning prevention. And so I remember going into folks' homes and providing them with all of the education about the dangers of health, of lead poisoning and so forth, and coming back with the sense of how effective am I being in this job, because then those people go back to the same dilapidated homes, to those same bad neighborhoods that had impacted them at the beginning. From that and the understanding that truly the issues that those parents were facing with the lead poisoning prevention were the same challenges that I was seeing as I was addressing immunization for children, or as I was addressing obesity or whatever, led us to start thinking about how can we impact differently? How do we truly address those underlying causes of health? What we talk about in public health as being the social and environmental determinants of health, but translate to things such as education. How good is my kid's school? Jobs. How good is my job? What kind of benefits do I have in my job? And so very concrete, the day-to-day factors that impact one's life. And those factors is not just a health outcome. They impact your overall life outcomes. And so how could we change? And it was the question that I kept asking, how do we do public health different so we are impacting all of these factors that are addressing every single one of my programs? And if we do not address them collectively, we are going to continue to not see change in outcomes, because we're not addressing the underlying causes. We are just having services and responding to a disease instead of what's causing and undermining all of our response. And so we decided to, you either continue doing what you've been doing or you change. And so we went all in, and we brought the team together. We thought it through, wrote the RFP, work with our community, let them know we're not going to be funding you as we used to do. So it's going to require of you a different approach. It's no longer one organization that we are funding. We are funding a community collaborative. So you need to bring that into your proposal. And we started the journey. And it's been almost 6 years now, 5 years. And it's been an amazing journey along with our community partners.
I love that. And, I think that you talked a lot about social determinants of health, and I appreciate that you brought that up because, having been in the healthcare space, working at American Heart Association and many groups in my career, social determinants of health were brought up, but really weren't concentrated on for a really long time. It was medical outcomes, clinical outcomes. It was looking at, the numbers and not looking at the underlying issues that are, truly driving those numbers, those healthcare numbers, right? And so many, I love the fact that, and it's for at least in my career, I've seen the last 7 or 8 years has been this renewed focus on, we have to look at all aspects of the human being,
Yeah.
right? We have to look at all aspects of, where they lay their head at night. Is it safe? Is it reliable? Is it secure? Is it, their ability to have, meals, adequate meals every day, their ability to make an income that is livable,
Absolutely.
all plays into your health and well-being. And that's been, I think that, my question for you on that is, I think we've seen that, in my opinion, even more now through COVID. We have seen this, how inequities plague the health outcomes of Rhode Islanders. We've seen more folks who, are struggling to make ends meet, are folks who are you're struggling the most, even more now since COVID. They're the one, we see so many folks getting sick,
Yeah.
and social determinants, I think, play such a critical factor. So I would just welcome your thoughts on how inequities have presented themselves through this crisis.
And I think when you mention COVID, it's really, that's the understanding that it's not new. I mean, we would be surprised if in a crisis and a pandemic such as COVID, the known inequities in health would not be exacerbated again. So it's not a new problem. COVID, it's once again bringing to light what we know we need to address. And so I think talking about COVID, it behooves us that we use this opportunity to truly look at our systems, not just our systems of care, but all of other systems that are creating or perpetuating the inequalities that we need to address. If you think about, for example, quarantine and isolation, if I'm going to be putting someone in quarantine and isolation and telling that person, you need to isolate from your family, you need to make sure you need to stay in your own bedroom, you cannot share a bathroom with people, how many families in our urban dense communities can afford that? How many families, when we know you have many kids and grandparents living together, can have that luxury to do that? If you do not have a steady job, can you really have groceries in your home for a full 10 days where you're not going to go home, or 14 days where you're not leaving your home? And so as a state, we need to create the systems to respond immediately to that. And I know we worked with United Way and 211 and Point and all of those for the immediate solution. But we need to start thinking about, how do we address then that underlying issue? How do we raise minimum age so we know that people have a livable wage, not just something to survive? How do we assure that our schools equally are addressing the outcomes and the educational outcomes of every single child in Rhode Island, so we have created a pathway for everyone to have a good job with good outcomes and everything else that it addresses? I think from a public health perspective, that realization leads you to think it's not just for us. It brings the fact that, and that's how I think also health equity zones, why it's a collaborative, it's because there is no single agency or no single organization or sector that can resolve this issue of outcomes. And so we need to come together. It means that my agenda needs to be part of your agenda, that the public health agenda needs to become the school, right, Department of Education agenda, and that those kids are my kids and my problem, the same way as the health of the population needs to be taken in consideration also from that perspective. From a healthcare system, it's a shift. I mean, it means that our healthcare system can no longer just see me as I walk in for my diabetes care. They need to be concerned about, can Anna have the appropriate access to food that is balanced and the diet that she needs? Does the neighborhood where she lives provides that to her? And I'm not expecting that the physician is going to resolve that, but that physician creates a network, and it's part of a network where he can rely on others in this continuum to provide that piece. And so it's creating these connections and these continuums of care where that start at the community level and go all the way through inpatient care, outpatient care, but all connected and talking to each other because families are the same.
Yeah, when the organization I led in Dallas before moving back home was an organization that serves senior citizens. And we would always say if someone was concerned that they were going to lose their home, they were also probably not eating 3 square meals, healthy meals a day. They were also making decisions whether they were going to eat or if they were going to
By
take their
medicine.
medications.
Yeah.
And that is reality for so many. And these decisions are affecting greatly. You think about kids' ability to concentrate in the classroom. Well, guess what? If they, were unaware of where they were sleeping that night, or if they didn't eat breakfast before they went to school, who's to say they're going to be able to fully concentrate in the classroom? So it all interconnects,
It
right?
is.
And
And I think as a state, we have the luxury to be able to have those conversations in ways that many other states don't. I think if we can, we have everything in Rhode Island to get it right. We are closed networks. We can have these kind of conversations, and these conversations can happen at the state level. We have a children's cabinet that is effective, that brings all of those different partners together, trying to make joint decisions for our children. So I think we have foundation organizations that are calling partners to say, what is the vision for the state that we want to put forward for a healthy state? We have it. We have so much expertise and I think willingness to do things different in our state. We just need to stay at it, go at it with strategy, and make sure that we carry our conversations beyond the conversation, and then we start moving to action in all of those different sectors. But I think we can do it in Rhode Island.
I agree. And I think Rhode Islanders have always had a can-do attitude, which I love. I love that our size give us the opportunity to test things and try things and be a national model for so much. We have lots to be proud of that, we've stepped in. Just yesterday, I received a call from a Florida journalist who wanted to do a piece around how we're tackling evictions and housing. People are paying attention to Rhode Island, and they should be. And the health equity zones, to me, is just such a great example of where we should have an immense amount of pride for what we've
We
done.
have, and you are right, and it's been recognized nationally. We've been invited to share the health equity zones framework by at many states. We received, in fact, also some funding from the Robert Wood Johnson Foundation to create a toolkit that we are almost done with, that will be distributed. It has two components. One component is how can a local community start a health equity zone, so guidance for local communities, but also guidance for states at the state level of what kind of changes do they need to do to be able to create these local health equity zones. We also saw ASTO, for ASTO as the National Association of State Health Officials. Last year, Dr. Alexander Scott was, our director was the ASTO president. She's now ASTO past president. But as ASTO president, she got to select a challenge, meaning that a framework that she would put forward to all other state health officers to try to address. And so the challenge that she put forward was, how can we build healthy communities using this health equity zone approach, putting community first in your health planning as a way of building healthy communities. And that's a challenge that is currently in place. And so we are seeing many states across many departments of public health across the US are looking at health equity zones and asking, how do we put community first? How do we create systems of care and response to this challenge of building healthy communities, strong, resilient communities, by putting community first. So more to come on that one.
That's great. And so in those, those other states that are trying it, what are their obstacles? Or is it that they don't have an infrastructure like we do? They don't have the support that we do? What are you seeing and hearing?
So many of them, they don't have an infrastructure. Many um, don't recognize that it took us 10 years. We didn't just woke up one day and did health equity zones. It was a journey, and we're still on that journey. So there's a need to buy in support from the leadership level, a need to do the same from the ground level, a need to reach out to your federal partners and make sure that they understand what's the vision, the goal. Some of that is done because of the success of the health equity zones that has been evaluated. We had audits and we passed all of those audits with no findings, which is great, meaning that we are in the right track. But I think there are some things like connected with how do you change your management of federal funds? The funding component, it's important because it's difficult to do the braided funding well. People are many times navigating the challenge of truly bringing and giving power to the community voice. It's not to be dismissed because people feel the pressure of their grant deliverables and what is their health outcomes. And you need to give time for this collaborative process, for the relationship building, and be okay that maybe you're not going to have in your first 6 months what you expected to have because you need to build this process. So some of their challenge have to do with staff also, staff turnover, lack of capacity at the local level. How do you bring into the process small organizations, and how do you make them feel fully empowered to be part of the process? Challenge with bringing residents' voice in a meaningful way into the process. It's something else that has been identified. And then bringing the state partners to the table, and in the way that doesn't overpower the community voice.
Got it. And a question from Facebook for you is how has it been around intergenerational engagement in the HESs? So things like, healthy aging activities within. So how is supporting our older adults kind of played into the role of HESs?
So it varies from, again, because this is a community driven, it depends if a community has identified it or not as an issue. And I know that at least two communities for sure, three cities in Pawtucket had identified that. Bristol, for example, is one that had put forward the isolation of their seniors as a problem, and they developed a series of initiatives within the city, same with Pawtucket and Central Falls. One project, I'm trying to remember which one of them did it, but there was one project where they engage youth to help paying, for example, during the winter time, I think that's when they did that. They had youth being allocated to going to visit some seniors and help with snow removal and so forth. So that was a intergeneration thing that they did where the youth had a job, a paying job, but at the same time, it allowed to address some of social isolation with the elder population. We've had some that use our seniors, for example, to bring them into school and do some reading. So it depends on the different health equity zones. Not all addressed a healthy aging. It's one of the things that it's interesting that we think through is how much at times, if something shows up that you feel it's important, but that was not identified by the community, we try to bring it over and we introduce it, but we do not force communities to address it. But we'd say, has this come up? And we invite our partners to bring that conversation in our learning collaboratives, for example, and say as a way of introducing, which is what we did, for example, with when we did drug overdose. We wanted to make sure while most, as I said, 8 out of them had already addressed it, we did that. We had funding to do diabetes. We wanted to do diabetes, but many told us not interested in doing diabetes control. And so you need to be able to truly allow for that process, and but also negotiate and say, "Ah, but maybe you can do that. And here are some ways of doing that, and here is some support."
Yeah, and I know in South County, I had the opportunity last year through Leadership Rhode Island to visit the South County
Yeah.
and what I really loved in that was that they were looking at suicide prevention. Suicide rates in South County are higher than other parts of the state, and ways that they could really bring formal training and certification, but also just conversation around mental health and suicide. And it was so cool to kind of see the passion that they had for that work, and the data drove a lot of their decision making, and where they were going to go and what they were going to focus on. So I loved that there was kind of that data driven decision making, but also just that deep rooted passion to serve and
And
to do this work.
that's how you create the true story. And so I used to say at the beginning to our health equity zones, yes, I can give you a data profile for your city, for the county, whatever data we have, but that's just one slice and one piece of the story that I can provide you. There's a whole other story that complements the data that you know better than I do, that every one of your community brings through the voice of the residents. And those together then make up the real picture and help you decide where you're going to go. So it's definitely informed by data, and it's definitely informed by the experience of those residents as they look at the data, but also on their day-to-day lives.
Yeah. I just want to take a little bit of flip, and we're going to wrap up in a few minutes. But, as Deputy Director of the Department of Health, you guys have been amazing, number one, and a little busy over the last couple of months. So talk to me about how the department's doing and how you guys are managing through what is one of the with both feet and a lot of passion for the work, for sure.
So I must say it's been extremely challenging. I don't think that none of us was prepared to a pandemic of this nature. I mean, we knew it was coming. We were prepared, on a sense. We were seeing the news, but it's taking an enormous toll in the department. It needed really the whole department to almost stop everything else that we were doing and respond at first and engage with a all hands on deck approach. And it's finally now that little by little we're starting going back to the normal work while continuing this engagement. I think a focus on at the beginning was truly in expanding our testing capacity, and I am so proud that we have the highest testing rate in the nation. It was a tremendous effort, and we have a whole team focusing on testing and expanding our testing capacity, expanding our testing locations. We are working hard on improving our turnaround times for results. We have some that are rapid results, some that need to be sent out. And because of the nationwide focus on testing, it's creating some delays that we're working on building our own capacity in the state. So that was one area. The other big area, case investigation, contact tracing, being able to, as soon as you find a positive result, to call that person, identify the contacts, place the person in quarantine and isolation, the same for their contacts, and then make sure that you have the appropriate supports for that quarantine or that isolation to be successful. And now, as we reopen our economy, continuing to monitor and provide the guidance necessary, the public health guidance that helps all of those different sectors reopen safely. Work with the healthcare system to make sure that we are building the infrastructure necessary if we have a surge, or if hopefully we don't, but if we were to have a surge and that our current capacity was all utilized, that you could move and have a structure where you can provide care, working with nursing homes and all of our elder structure of care to make sure that they are protected, that we can provide timely testing to the staff and to the residents so we can reopen for visits, because we all want to see our loved ones. And now for me, the other next one is a focus on education, making sure that as comes end of August, September, we can reopen safely. and our kids are in schools that are prepared to receive them, and we are working hands in hands with the Department of Education, making sure that that is the case. And last, this is summertime. We all love summer in Rhode Island. We love going to the beach. We love having barbecues in our, having social gatherings in our backyards. But let's do that safely and keep remembering that's the best way, using our masks, washing hands frequently, keeping the 6 feet distance, keeping our social network close, always, always. And if we are sick, let's stay home. You know, this is not the time for perfect attendance. This is not the time for, oh, I'm feeling sap. I can make it at work today. No.
No.
So keeping those things in mind will keep ourselves, our families, and our communities safe. And we'll be able to reopen the economy, open our schools safely too.
And be nice and respectful and know that everybody's going through this really
Absolutely.
tough time, you know. And I love that there's a campaign, Frog and Toad, is just be nice, be supportive of the folks around you. We're all going through this really crazy situation.
It is hard, but we together, I think we can do it. Rhode Island is a good place. Very low number of cases now, still declining or stable, a low level of hospitalizations. We keep doing good. So our measures look good, our monitoring looks good, but we need to keep the behavior well. We need to not be crowded as we go to Block Island, not be crowded or wear our masks all the time. I love going to the beach. So go to the beach, enjoy the beautiful coasts, but let's do it safely with our masks, keeping our 6 feet distance.
Yep.
We
have one of our team members who loves the beach as well, as do I, but she puts cones where her family is all around, and people honor it. And I think that that's great. These are the types of things we got to do this year, right?
You know, innovation and creativity that we have also at our own individual level. My kids gave me a towel that is a round towel that is higher, that has the 6 feet distance. It's enormous, but hey, I feel safe in my little corner.
Exactly. And we've been so honored at the United Way to partner with the Department of Health from day one. We received a call the night before the announcement. I was at the March 1st announcement, and we've truly been proud to provide support around quarantine and isolation and supporting residents who are in quarantine and isolation, access to locations of testing facilities. I mean, you name it. The United Way and our 211 program has been proud to be your partner through this process.
You know, you've been an amazing partner. I think the state has done an amazing job. I've really seen the state come together as a state. It's been a state whole of government response. National Guard has been an amazing partner of ours in supporting our communities, supporting our contact tracing. They've been there all along with us. Commerce, we spend hours with Commerce in discussions and making sure that businesses are opening safely, that bars and restaurants, little by little as we reopen, we do it with public health in mind. And now we're doing the same with education. And so it's been a tremendous honor to be part of this response, but even more to see how people came together, government came together in such a powerful way, along with our community partners such as you, to respond. And so now it's for us as individuals to do also our part, continue to do our part because we're doing very well. So we continue this sail towards stability, steady state as we move forward.
Agree.
And so for the vaccine.
Yes, and I always like to end these conversations with calls to action, and so I hear loud and clear: wear your mask, socially distance, but do more research and look up what's happening with the Rhode Island health equity zones, and learn more of the great work that's happening, and reach out to them. There's a lot, volunteer opportunities. You can learn more and participate in those community conversations. It is your neighborhood, your community, and you are responsible for its health and well-being. So Ana, thank you so much for your time. It's truly an honor to just sit with you and chat with you, but also just learn about the great work and the contributions that you make and your team makes each and every day to our state.
Well, thank you so much for inviting us to share the story of HAS, the opportunity to talk a little about COVID and what to do. And so I have appreciated your partnership, the United Way, and I look forward for us continuing to work together on health equity zones, on COVID, and many other things that United Way plays such an important role in our communities, in our state. So thank you.
Thank you. Thank you. And thank you to everyone who watched. We appreciate you. We appreciate the questions. Next week, we're going to be talking with Books Are Wings and Jocelyn White. We're going to be talking about summer reading options for kids. I don't know if you guys are anything like my family, but we need new ideas midsummer of things to do with our children and great books to read. So I absolutely am looking forward to next Friday in our Community First Conversations. If you want to learn about the work that's happening at the United Way and our partners throughout the state, our handles are Live United RI and our website is liveunitedri.org. That's it for this week's Community First Conversations. Have a great weekend, everybody.